All right, we're going to go to mood disorders part 3, which is going to discuss other mood disorders, and these I've listed in yellow. So we'll go through these and define them. So disruptive mood dysregulation disorder. This was a new disorder introduced to the latest version of DSM, which is DSM-5. The reason that they had introduced this new disorder was because a lot of kids were being labeled with bipolar disorder on the basis of their irritability and their temper tantrums. This led to an entire generation of kids being labeled with bipolar disorder and being placed on long-term medications with significant side effects that would be not only during the course that they were taking the drug, such as an antipsychotic, but with long-term implications from taking these powerful drugs. So the whole debate, why are we labeling all these kids with bipolar disorder? In fact, many kids who seemed like they were bipolar went on to develop either anxiety in adulthood or major depression in adulthood and never had a full-blown manic or hypomanic episode. So anyway, this applies to children below the age of 18. They're irritable, they throw temper tantrums. Note that irritability in adolescence is a manifestation of depression and should not be misconstrued as bipolar. So one test question you might get is an adolescent who's very irritable, but will also meet the criteria for a major depressive episode. But you should know that irritability is a main sign of a major depressive episode in an adolescent. Premenstrual dysphoric disorder, known colloquially as PMS. It starts in the week prior to onset of the menses, improves within a few days of the onset, and they have no symptoms or minimal symptoms at any other time during the menstrual cycle. It can't be exacerbation of a depression that exists independently. It has to be purely around the menses. And this is interesting, it can be treated with phasic SSRIs. What do I mean that? You can take Prozac, for example, or Zoloft, which is fluoxetine, sertraline, or paroxetine, which are SSRIs. And a woman will just start the medication during the luteal phase, 2 weeks, and then the other 2 weeks won't take anything. And that will prevent premenstrual dysphoric episodes. So a very interesting twist on treatment for depressive episodes. Okay, other mood disorders. Oh wait, before we do that, we've got a question. Student sitting next to you reveals to you that he regrets having gone to medical school. This may remind you of many of your colleagues. Endorses 2 months of low mood, lack of interest, problems concentrating, and feels like he's less capable than his classmates. He's having difficulty sleeping, has a poor appetite. He's not suicidal, but he is thinking about dropping out of medical school. Which of the following is his diagnosis? So he meets the criteria for a major depressive episode. He meets the CIGI-CAPS criteria. But let's see what he has. Bipolar 2, cyclothymia, major depressive disorder, persistent depressive disorder, none of the above. The answer is none of the above. Now you're going to be shocked by that, but the reason is episodes and manic episodes are not disorders. They're kind of syndromes, a constellation of symptoms that can be found in a variety of psychiatric and medical disorders. So looking at this question, I don't know if he's ever had hypomania. I'm sure he doesn't have cyclothymia because this is not subsyndromal, it's the real deal. I can't call him having major depressive disorder without knowing about prior episodes of hypomania or mania, or whether he's had it for, actually, I can't call it persistent depressive disorder because it's only been 2 months. It could be a substance-induced mood disorder. We don't know if the guy is drinking alcohol or using drugs that might induce depressive symptoms. We don't know if the guy has a medical disorder such as hypothyroidism, which can mimic a major depressive episode. So we have to say none of the above because we just don't have enough information. Now, if you saw this on a test and you were forced to choose one of these disorders, of course you would choose major depressive disorder. But in real life, in real clinical practice, this is not enough information to make a diagnosis. I want to just show you how this concept is no different than concepts in other areas of medicine. So this person can have an episode of congestive heart failure. Well, that can be due to ischemia. It can be due to a dilated cardiomyopathy, hypertrophic cardiomyopathy, liver failure, kidney failure, and many other things can cause congestive heart failure. A major depressive episode could be due to major depressive disorder, persistent depressive disorder, bipolar 1, bipolar 2. Depressive symptoms can be induced by substances or they can be due to another medical condition. So just because a person has congestive heart failure, you have to understand why they have it in order to give them a diagnosis. So just like a major depressive, you have to know, well, why do they have this? We recognize the constellation of symptoms. Why do they have this constellation? And you got to go through your various differential diagnoses and figure out which one of these do they have. And that's what I do for a living. Okay, so let's look at these other mood disorders, which we have alluded to. So substance-induced mood disorder. This is different than intoxication or withdrawal, but I want to remind you that intoxication with drugs can cause depression or mania, depending on which drugs you're taking. Withdrawal from a drug, when a person comes down from cocaine, they can become suicidal, and we see this all the time. A person after a cocaine binge comes to the ER, absolutely suicidal. Their urine toxicology screen is positive for cocaine. You watch them for 24 to 48 hours. They feel great. They want to get the hell out of the ER so that they can go use some more drugs. Same thing with amphetamine. Now, we don't call this substance-induced mood disorder, although many people will call that. It's really drug intoxication presenting as mania, or drug withdrawal presenting as depression. What we mean about a substance-induced mood disorder is that the patient has symptoms even when they're not using. So daily drinking, for example, leads to symptoms that can completely meet the criteria for a major depressive episode, even when the individual is not inebriated or withdrawing from alcohol. They may have a coexisting major depressive disorder and an alcohol use disorder, which they could have both together or they could have one without the other. The mood improves within weeks to months of alcohol cessation, and any psychiatrist will tell you they've got a lot of people like this, where the substance the person was taking was the cause of the mood disorder, and then when you took it away, took the alcohol or the drug away, within weeks to months, the patient's mood improved markedly. And as long as they stay away from that substance, they will be free of mood episodes. So the question when they come in to me is the patient medicating himself with alcohol, in which case it's a primary mood disorder? Is the substance causing the depressive symptoms, in which is primarily a substance use disorder, or do they have a dual diagnosis? So you'll hear the term dual diagnosis. That is used exclusively for people who have a psychiatric disorder plus a substance use disorder. Now, substances don't just have to be illegal drugs. They can be prescription drugs. And if you look at any book on adverse events associated with drugs, you'll see that almost every drug has same case reports on depression, psychosis, or suicidality as a result. But I've listed here some of the interesting ones that have come out in the last decade or longer. Steroids like prednisone, notorious, can cause either depression or mania. Birth control pills have been linked to depression and even suicidal ideation. The acne drug isotretinoin kind of well known to be associated with depression. Even the asthma drug montelukast, the smoking cessation drug varenicline, and then oseltamivir, which is Tamiflu, which is the drug for flu. All of those have had linkages with psychiatric episodes. And any drug that acts on the central nervous system, including psychotropics, including antidepressants, can actually cause or exacerbate a major depressive episode. So, to be following strict criteria from the DSM, you can only call it a substance-induced mood disorder if the symptoms last longer than what would be expected from just intoxication or withdrawal. There's a special case, very important for you to know. If a full hypomanic or manic episode emerges after treatment with an antidepressant, we consider the patient having had bipolar disorder. So, an antidepressant-induced manic or hypomanic episode is called bipolar 1 or bipolar 2 disorder. Another example where an episode defines a disorder. Okay, and then we need to do mood disorders due to another medical condition. All these psychiatric disorders are medical conditions, but sometimes they can be due to another medical condition. The major areas in which this occurs, neurological disorders by far. So there's a whole list of disorders here that can be associated with mood episodes. Then you have the whole endocrine metabolic situation, not just the famous hypothyroidism, but hypoadrenalism, Cushing's disorder, where you have high levels of endogenous steroids, B12 deficiency, renal failure, liver failure, and even hypercalcemia. All of these have been associated with mood episodes. Infections of the brain, HIV, syphilis, tuberculosis, and then cancer. The famous one is pancreatic cancer, where a patient can present months before anyone knows they have pancreatic cancer, before any other symptoms. They just have depression. And you've got you may have no clue, but then within 6 months, boom, they become jaundiced, they're worked up, and they found to have a pancreatic mass. Now, disorders due to another medical condition, we only use this if there's a direct physiological consequence of a condition known to cause psychiatric symptoms. It's not about, oh, this person has severe osteoarthritis, well then it's a psychiatric, and they're depressed, well they have a psychiatric disorder due to another medical condition. No, because there's no known physiologic link between osteoarthritis and mood disorders. So in that case, when it's a severe disabling medical illness that's not known to have this direct physiological link and the patient is depressed, we call it a major depressive episode, which may be due to major depressive disorder or any of those other disorders that we described. So that's an important point. We can only call it a disorder due to another medical condition when there's a known linkage between that medical condition and a mood episode. So, gee, that makes things hard, because what are the clues to make you think that the episodes are due to another cause, either substance or a medical condition? Well, nature gave us a little gift to psychiatrists in that the age of onset of most psychiatric disorders is below the age of 40, and the age of onset of many serious medical disorders is after the age of 40. So age of onset is clearly a clue that you're talking about a secondary cause. Patients with psychiatric illness almost always have family members that have had psychiatric illness. So if you have somebody who there's just no history of having a depressive episode or a manic episode or any kind of episode before, and they have no family history, there you have a heightened suspicion that this is due to another cause. Depressive individuals, as we talked about, often have somatic symptoms. Even manic patients have somatic symptoms. But if it's a somatic symptom other than pain, like frequent urination or frequent bowel movements, now that can occur in a major depressive episode. But if they've got those other symptoms besides pain, you have to dig a little further to see, could it be another medical condition that's presenting as depression? Any patient who started or increased the dosage of any new medication or substance in the previous 3 months, you have to have a heightened suspicion that perhaps, especially if they've never had depression before, perhaps it's this medication or substance that's causing the mood disturbance. And also, every person that comes in with psychiatric symptoms, there's almost always a stressor, a conflict with a significant other, a financial loss, a loss of a job. So if you have absolutely no stressors, you don't have any family history or prior history of psychiatric illness, your age is over 40, you've got physical symptoms other than pain, that's another medical condition until proven otherwise. Okay, then you got this basket thing where you've got, as we talked about with hypomania, there's things that don't quite fit the disorders that we've already described, but they do have significant distress and perhaps some functional impairment. And even though they don't meet the criteria, we will call that other specified or unspecified disorder. So example, first I have full hypomanic episodes and mild depressive episodes. We can't call that cyclothymia because for cyclothymia, it's subsyndromal hypomania and subsyndromal depression. But if they have this and it's causing some issues, it would be bipolar disorder, other specified or unspecified bipolar disorder. Manic episodes that last less than a week, or people who meet the criteria for depression but without anhedonia or sadness, those would be examples of mood disorders that are unspecified. All right, now, what else can present with depressive symptoms? An adjustment disorder. All right, so what if something bad happens? I have a financial loss, I break up with a significant other, etc., and I get sad. I just normally sad after something bad happens. Are you going to label me with major depressive disorder? And how am I going to get life insurance? Because it's very hard to get life insurance if you've had a psychiatric illness. I can just tell you that right now. Anyway, so stressful situations arise in everybody's life. And most of us have coping mechanisms, seeking social support, doing things that we find pleasurable, distracting ourselves. But some people get to feel overwhelmed and they develop symptoms of depression or anxiety or both, to the point where functioning is impaired, but they don't meet those criteria that we talked about. So major stressor, got depressive symptoms but don't meet the criteria, we would call adjustment disorder with depressed mood. It can also be adjustment disorder with anxiety. It can be adjustment disorder with depression and anxiety. There can even be adjustment disorder with a behavioral disturbance. So you can have 3 different types or 4 different types of adjustment disorders depending upon what the symptoms are. This is so important because, again, the tendency for physicians is something bad happens to the patient, they've got a depressive episode, and they meet the criteria, but I'm going to say, well, anybody would get depressed. No, if they meet the criteria, they've got a major depressive episode. Very important for you to understand. They meet criteria regardless of what the stressor is. We call it a major depressive episode. Doesn't mean that they need to have medications. Doesn't mean that they necessarily need psychotherapy. But you got to keep an eye on somebody like that. Now, for others who don't meet the full criteria, we call it an adjustment disorder. An adjustment disorder must occur within 3 months of an identifiable stressor, emotional or behavioral symptoms like we discussed. There's got to be distress that's marked, or impairment in functioning, and they don't meet the criteria for a mood episode. So they occur within 3 months of the onset, and they resolve within 6 months of the termination of the stressor. So, kind of have to know this 3-month, 6-month rule. Again, it's arbitrary, but we had to put the cutoff somewhere. So medication is typically not needed, except they may need hypnotics for sleep. Psychotherapy or watchful waiting is the treatment of choice. All right, what about bereavement? So in the DSM-IV, bereavement was given a separate diagnosis. The consensus in DSM-V was to take out bereavement. And the reason, again, is the experts were worried. Patient comes in after a significant loss. They have all the criteria of a major depressive episode. Physician says, it's bereavement. You're going to be okay. You're fine. Everybody feels this way. And what's going to happen? They're going to miss those few people who actually go on to kill themselves. So the authors wanted to kind of take bereavement out. And if the person meets criteria, then it is major depressive episode. And here you've got some of the bullet points about that. When it comes down to it, the clinician has to use judgment if you're going to classify it as grief or a psychiatric disorder. And for me, if it lasts longer than expected, if it's extremely intense depression, if a person just can't even go back to work, 2 weeks or longer after the death, if the duration is months rather than a few weeks, then I would then start calling it a major depressive episode. But per the DSM, if they meet criteria, that's what they have. So in grief, sadness comes in waves. Person can still have humor and moments of levity. There may be wishes to join the deceased, but no active desire to do so. They're able to look forward to a future. They have guilt, but the guilt is associated with how they treated the deceased person, not guilt generalized to other things. They may even have visual hallucinations of the deceased. That's considered normal in many cultures. And they have just a little or slight motor retardation or agitation. However, in depression, the sadness is unremitting. They can't experience pleasure even for a minute. Intense and persistent suicidality. Nothing to look forward to. They feel worthless and guilty about things other than the deceased person. The hallucinations are not visual hallucinations of the deceased person saying something reassuring, but instead they're hallucinations of rats running around in the apartment, or hearing voices telling them to kill themselves. And there is usually marked retardation or agitation. Here you've got all the mood disorders. And let's look at this question here. 62-year-old guy, just been diagnosed with metastatic prostate cancer. Used to be healthy. Experiencing now low mood, inability to experience pleasure, insomnia, fatigue, and feelings of guilt about the impact of his illness on the family. They've been present most of the day for 3 weeks. He doesn't drink alcohol, use recreational drugs. He's never had any psychiatric symptoms in the past. The most likely diagnosis, the answer is major depressive disorder. Why? Well, there's no known link between prostate cancer and depression. I mean, people may have a higher incidence than they do after a diagnosis of cancer, but there's no known physiological link between the two. So we can't call it a mood disorder secondary to the prostate cancer. Now, it could be adjustment disorder with depressed mood, but look at it, he meets criteria for SIGI-CAPS. And we definitely can't say, well, he's having a normal reaction to a life-threatening illness. That's a very important thing to recognize. That you meet criteria, you're having an episode. One question that people ask me, well, why don't you call this a major depressive episode, but instead you're calling it major depressive disorder? Because the questions pretty much rule out by saying never had psychiatric symptoms in the past, so there's no been history of mania or hypomania in the past, doesn't use alcohol, recreational drugs, and of course we know that we don't know of any physiologic link between prostate cancer and depression, so we've got enough data here to exclude other conditions and call it a major depressive disorder. Okay, we're going to take a break now and discuss the epidemiology in our next lecture.